pushed around by fears in your mind. Be led by dreams in your heart. So whatever you're studying right now, don't read it with that attitude that what if I do not clear the exams? If I do not get a seat in the for specialization or for PG entrance, what will I do? Will I ever get a job then? What will my parents say? Will my friends make fun of me? All my relatives will feel that I'm not worth. So whatever you are doing right now, whatever you're learning right now, do it with that attitude that you are learning so many new things, and this learning that you're doing is to improve your skill. That is to make your life beautiful and to help make others' life beautiful. And yes, everybody has a job, but not many people are blessed to be in a profession where they can relieve the sufferings of others. You are the one who is blessed to be in this profession. So make the best use of it. Whatever you are learning, do it with a lot of love. So with that, we start with a very, very important topic of the larynx, and that is the vocal cord palsy. Now, many questions are asked from the vocal cord palsy, and this is something that you find a little confusing, but yes, it is very simple if you understand it. So with that, we start with the vocal cord palsy. And yes, before we start with that, we need to know the nerve supply of the larynx, the very, very important nerve supply of the larynx. So can you tell me the larynx is supplied by which nerve? Very good, the vagus. The vagus comes out through which foramen? Very good, the jugular foramen along with, yes, 9th and 11th cranial nerves. Okay, so now let us see the complete course of the vagus and how and what branches it gives to the larynx. So, in the jugular foramen, the vagus has two ganglions, the superior ganglion and the inferior ganglion. The moment the vagus comes out, the jugular foramen is somewhere here. Immediately from the superior ganglion, it gives a branch that supplies the ear. Do we know that name? Yes, that is the auricular branch. Can you tell me exactly what it is known as? Yes, the Arnold's nerve. Very good, Arnold's nerve. Now, just below that, it gives another branch that gives a branch to the pharynx. Now, this pharyngeal branch, along with the 9th and along with the sympathetic chain, forms the pharyngeal plexus. And this pharyngeal plexus gives, yes, here the vagus mainly gives the motor supply to all the pharyngeal muscles, the pharyngeal constrictors. Yes, glossopharyngeal also gives the supply to the stylopharyngeus, but major, all the constrictor, the longitudinal muscles of the pharynx responsible for constricting and for swallowing movements. Also the muscles of the palate, they are supplied by this pharyngeal plexus. So that is the pharyngeal branch. Now, below that, from the inferior ganglion is given of the superior laryngeal nerve. Now, the superior laryngeal nerve, it comes down. Now, it is coming down as a separate nerve from the vagus. Yes, just try to understand this. So now, when it comes down at the level of the hyoid, it divides into two branches. Yes, the one that enters the larynx is known as the internal laryngeal. It is supplying the larynx, so it is known as laryngeal. It is entering the larynx, so it is external. It is internal. The other one that does not enter the larynx is what is external laryngeal. So the two branches of the superior laryngeal nerve are the internal laryngeal nerve and the external laryngeal nerve. The internal laryngeal, we have seen in the anatomy, it pierces the thyroid membrane and it enters the larynx. It gives a sensory nerve supply to the larynx and to the hypopharynx above the two vocal cords. So the superior part of the larynx, that is the supraglottis, the sensory nerve supply is by the internal laryngeal nerve. So if we want to take a biopsy from any of these areas in the supraglottis or in the upper part of the hypopharynx, we need to anesthetize this nerve. Yes, and where do we anesthetize this? Exactly here where it is piercing the thyroid membrane. So where we anesthetize, we have seen that already in the anatomy. Now, the second branch is the external laryngeal. As the name, it remains externally. And what does it supply? It supplies the only intrinsic muscle of the larynx that lies externally. Can you tell me the name of that muscle? Yes, very good. Lies externally between the cricoid and thyroid. Cricothyroid muscle. So, this is supplying the cricothyroid muscle. And what is the cricothyroid muscle? It is a muscle for what? Yes, it is a muscle, it is a tensor, it is a adductor as well as a tensor of the vocal cord. So we know now that if the external laryngeal nerve is injured, what will happen? The vocal cords will not be able to tense. The pitch will not be able to raise. If the internal laryngeal is gone, what will happen? Your sensation above the true vocal cord will go. So if the sensation of the supraglottis is gone, what is sensation useful for? Definitely it takes the pain. In any condition there is pain because of the internal laryngeal, the sensory nerve. More important is, yes, if the sensation is gone, then there will be repeated aspiration, because wherever the foreign body is going, into the supraglottis is where it reaches first. So if the supraglottis is not able to sense it, there will be aspiration that can lead to lung complications. So now the second branch of the vagus, that is what is known as the recurrent laryngeal. Why it is known as recurrent, we'll just see. So this recurrent laryngeal has a different course on the right and the left side. On the left side, the recurrent laryngeal is given off at the arch of aorta, and now we can see it is coming up in the opposite direction as the main trunk of vagus. So that is why it is known as recurrent. So here it runs in the tracheoesophageal groove and it ascends up. And yes, we are seeing here that it ascends up in the tracheoesophageal groove and then it enters the larynx. Now, where the internal laryngeal enters the larynx, that we had already seen in detail in the anatomy. Yes, it is at the upper border of inferior constrictor, in between the middle and the inferior constrictor. Do you remember that? Did you remember that? Okay, very good. We saw this in pharynx in great detail also. So now the recurrent laryngeal enters in between which two muscles? Yes, that is in between the inferior constrictor and the esophagus. So at the lower border of inferior constrictor, it enters, and behind the cricothyroid joint, it enters the larynx. Now the recurrent laryngeal nerve, what does it supply? Yes, it gives a sensory nerve supply to the larynx at the level of the true vocal cord and below that. That is, what is the level of the true vocal cord in the larynx known as? That is glottis. Below that is subglottis. Yes, so glottis, subglottis, the sensory nerve supply is by recurrent laryngeal. Supraglottis sensory nerve supply is by internal laryngeal. Yes, and not only that, recurrent laryngeal is the major motor nerve supply of the larynx. The recurrent laryngeal gives motor supply to all the muscles of the larynx except you will tell me. Yes, except the cricothyroid. That is the only muscle that is not supplied by recurrent laryngeal, and that is supplied by which nerve? Yes, very good. That is supplied by the external laryngeal branch of superior laryngeal. Okay, so now here is it important to know exact course also of the nerve? Yes, it is important to know the course. So now we saw the left recurrent laryngeal. Is it different from the course of the right recurrent laryngeal? Yes, it is different. On the right side, the recurrent laryngeal is given up higher up in the neck at the subclavian. It curves around the subclavian, runs in the tracheoesophageal groove, and now the next course is the same. It enters the larynx. The supply is also the same. Sensory nerve supply to the larynx at the glottis and subglottis, and motor to all the muscles except for cricothyroid. Now here what we need to know is exact course of the nerve. Why do we need to know the exact course of the nerve? Because the question that is asked in your exams recently, what are the questions? The following base of skull surgery, patient presents with stridor, hoarseness, whatever aspiration, whatever complaint is given of the larynx. But what is mentioned? Base of skull surgery. Or following carotid triangle surgery, patient presents with hoarseness, stridor, whatever. Yes. Following mediastinal surgery, cardiac surgery, patient presents with this. Following esophageal surgery, patient presents with this. Thyroid surgery, patient presents with this. So when it is given like this, we should have an idea just by reading which area is getting operated, that what are the branches there. What can be injured in that area? Yes. So if there is a base of skull surgery, yes, base of skull surgery, then there can be a complete palsy of the whole of the vagus. All the branches of the vagus will go, which means that the auricular branch will also go. There can be anesthesia in the part supplied by the auricular branch, the Arnold's branch. More important is the pharyngeal branch. If the pharyngeal branch grows, if there is a base of skull surgery, then what will happen? There will be difficulty in swallowing. These muscles are responsible for pushing the food down, for swallowing movement, for deglutition. So there will be dysphagia. There will also be the palate movements will go. There will be regurgitation of food. Yes. So along with the laryngeal complaints, there will be the additional complaints. So you will come to know that yes, the nerve is injured quite high up before the pharyngeal branch is given up. Along with that, there it is accompanied by other branches, the ninth nerve also. Yes, so there can be involvement of other cranial nerves also. So maybe there are features that are mentioned like that also. Now suppose if it is a base of skull surgery, okay, base of skull surgery. So in base of skull surgery, is it necessary that there will be complete palsy only? we are seeing that in the level of the base of skull can be at this level, base of skull can be a little higher at the jugular foramen. Yes, so if there is any base of skull surgery that we are doing, then it is also possible that the injury is here, which means that specifically the superior laryngeal only can get injured. Yes, so patient can present only with features of superior laryngeal injury. So don't think that only if the features of superior laryngeal injury is present, the injury has to be lower down somewhere. No, in the base of skull also superior laryngeal nerve is given off as a separate nerve. So it can get separately injured at that level also. Now also if there is, for example, was a question given that there was following carotid triangle surgery. So where is that carotid triangle? Yes, we know that this area that is bounded by the posterior belly of digastric, the omohyoid superior belly, and this is the sternocleidomastoid mastoid. This is the area of the neck that is the carotid triangle. And how is it important here? Yes, we know that at the level of the hyoid, this nerve divides into the internal branch and the external branch. So in the carotid triangle, if there is injury, there can be injury to the complete trunk, the superior laryngeal. There can be separate injury to the internal laryngeal. There can be injury to external laryngeal. The external laryngeal nerve accompanies the superior thyroid artery. So sometimes it is mentioned that while ligation of superior thyroid artery, some nerve got injured and patient presented with inability to raise the pitch. Yes. So even before you see the symptom, you know superior thyroid artery. So which nerve is accompanying the superior thyroid artery? Yes, that is which nerve? The external laryngeal nerve. Or when we are talking about the recurrent laryngeal nerve, where it enters into the larynx, it is intermingled with the branches of inferior thyroid artery. It either passes above it or in between or below the inferior thyroid artery. So while we are ligating the inferior thyroid artery, there some nerve gets injured. So you get an idea which nerve would have got injured. The recurrent laryngeal nerve, along with inferior thyroid, the recurrent laryngeal nerve. If it is given cardiac surgery, which will get injured? The right or the left recurrent laryngeal nerve? Yes, which one goes down in the mediastinum? Yes, only the left recurrent laryngeal nerve. The right is given off quite higher up in the neck. So that will not be injured in mediastinal surgeries. It will not be injured in cardiac conditions. Now that we know the course of the nerve, can you tell me which will be more prone to injury, the right or the left? Obviously, the longer course is the left. So more prone to injury will be the left. Yes, neck conditions can affect both, right as well as left. When we are operating on the larynx, when we are operating on the esophagus, the hypopharynx, when we are operating on the cervical spine, where we are going from anterior, both can be injured, right as well as left. Whereas in mediastinal surgeries, only what can be injured is the left. In heart surgeries, only the left can be injured. If there is any mediastinal condition like bronchogenic carcinoma, which can be injured, only the left can be injured. If there is any condition like Ortner's syndrome, have you heard of that? Ortner's syndrome. What is Ortner's syndrome? Yes, mitral stenosis leading to hypertrophy, dilatation of the left atrium. So left atrium, if it is enlarged, it will compress which laryngeal nerve? Yes, the recurrent. Which side? The left recurrent laryngeal nerve. So this is what is known as the cardiovagal syndrome. So more common palsy is of the left. It can be affected both by neck and mediastinal conditions. Now, when we are talking about the neck, in the neck, more common to be injured is the right. Both can be injured, but in the neck, more common to be injured is the right. Why right? Because on the left side, the nerve is present consistently, mostly below the branches of the inferior thyroid, whereas here it is more intermingled with the branches of inferior thyroid, so it is more prone to injury on the right side. So this is what we need to know about the course of the vagus. Okay, so before we go to that, quickly you're going to tell me that how many branches of the vagus do we have which supply the larynx? Yes, very good. Which branches? Superior laryngeal, the other is recurrent laryngeal. Superior laryngeal is given off where? Very good. At the base of skull, inferior ganglion. It divides into how many branches? Internal and external. Okay, and what is the other branch? Recurrent laryngeal. Okay, so now let us write the nerve supply of the larynx. The nerve supply of the larynx, the sensory nerve supply. Yeah, sensory nerve supply is by the supralaryngeal internal branch of the supraglottis. So supraglottis is supplied by internal laryngeal nerve. What is the sensory nerve supply of the glottis and subglottis? Yes, it is recurrent laryngeal nerve, and subglottis is also recurrent laryngeal nerve. Okay, what is the motor supply of the larynx? Yes, motor supply, we know all the muscles of the larynx except the cricothyroid is supplied by the recurrent laryngeal nerve. And what is the cricothyroid supplied by? Cricothyroid is supplied by external laryngeal nerve. This is a branch of superior laryngeal nerve. Here again, superior laryngeal branch, superior laryngeal nerve. Okay, so now we know all the complete nerve supply of the larynx. So now let us see that when these nerves get injured, what is the presentation of the patient? Because the patient will come to us with some complaint. The question what will be mentioned will be the complaint. If the site is mentioned, very good, you can get an idea which nerve. Otherwise, we have to find out by the or reconfirm it by the symptoms of the patient. So before we go to that, we need to know the various positions of the vocal cord. What are the various positions of the vocal cord? Yes, so if here I will draw it for you, and this is what you need to draw, and you need to know what you're drawing. So here we have the epiglottis. We have drawn it so many number of times whenever we get in the exam. So this is the epiglottis. We have the aryepiglottic fold on both the sides, and this is the arytenoid. Yes, in the center is the arytenoid. So now what are the positions of the vocal cord? We have the various positions. This is the median, that is exactly in the midline. Then we have the paramedian. Then paramedian is 1.5 millimeters from the midline. Then we have the intermediate, and then we have the slight abduction and full abduction. These are the various different positions of the vocal cord in various activities of the larynx. Yes, it can be the median, or it can be a little more lateral, that is paramedian, little more lateral, that is intermediate. So what is the distance of the vocal cord when it is in median, paramedian, all these positions? Yes, so let us quickly write it down. If the position is median, median is exactly in the midline. Paramedian is little more laterally, that is 1.5 millimeters from the midline. Intermediate or cadaveric is 3.5 millimeters from the midline. Slight abduction is even more lateral, that is 7 millimeters from the midline, and full abduction is 9.5 millimeters from the midline. Now, when do these positions normally occur? So we know that the vocal cord can be in all these positions during different activities of the larynx. So what are these activities which lead to these in which position is the larynx in which activity? So let us see that. The median position of the vocal cord is exactly the midline position of the vocal cord when both the vocal cords are in the center, that is they are adducted. So the median position of the vocal cord will be present when we phonate. Whenever we phonate, what happens is that both the vocal cords meet in midline. The subglottic air pressure builds up. When it crosses a particular level, it is released, vibrating the vocal cord, and that we turn into speech. So this is the position that we require during speech when we are speaking. When I am speaking now, my vocal cords are in the median position and they are vibrating. I am turning it into speech. The second is the paramedian. So what is the paramedian position? Yes, paramedian position is during whispering. During whispering, can you see there is a little leakage of the air? The sound is a little breathy. So that is during, whispering, the position of the vocal cord is paramedian. So median is during phonation, during speech. Paramedian is during whispering. Now, a little more lateral, that is intermediate. Intermediate, when is the position of the vocal cord intermediate? Yes, intermediate is the neutral position of the vocal cord. Now, why do we call it neutral? Because if I ask you that the right vocal cord is 3.5 millimeters from the midline, is it adducted or is it abducted? Yes, this is neutral, none, neither adducted nor abducted. Adduction and abduction occur from this neutral position. So that is why it is known as intermediate position. So when will it be that this is in the intermediate position? When will the vocal cord be in the intermediate position? Okay, when you give anesthesia, when there is neither adduction nor abduction, neither is the patient speaking. Yes, okay, so that is more important. It is known as cadaveric. Why is it known as cadaveric position? Okay, very good. When it will be seen in cadaver. Excellent. Okay, so it is seen in cadaver. So when a cadaver will come to ENT OPD, you will do the IL examination and his vocal cord, you will find it like this. Is that? Yes. What's the meaning of cadaver? If one side has become a cadaver, means all the nerves of that side have gone. All the nerves means, which nerves are we talking about? Is the complete supply of the larynx of that side has gone, which means that all the branches, the superior as well as the recurrent of the right side has gone. Which means if there is a complete palsy of the vagus of one side, that particular vocal cord becomes cadaveric. Now, what we need to know in the vocal cord palsy, very, very important, is that the vocal cord palsy can be either complete or incomplete. We'll just come to that later on. For now, what you're seeing is one vocal cord palsy, you know the position of vocal cord, complete palsy. If the complete vagus of one side is gone, which means where can be the injury? Yes, it can be an injury at the level of the base of skull. So both the right side superior as well as recurrent has gone on one side. That is the base of skull lesion, base of skull injury, whatever it is. Yes, at the level of base of skull. So there will be complete palsy, because I don't think somebody is such a wonderful surgeon that while operating, that person can manage to injure superior, recurrent, internal, external, and recurrent, everything, all the nerves of one side. Yes, that usually does not happen. So usually if there is complete palsy, the lesion is high up in the base of skull. Okay, so now this is what is the cadaveric position. Slight abduction is during normal respiration. Full abduction is during forced respiration. So slight abduction is during normal respiration and full abduction is during forced respiration. And what is intermediate? Intermediate is a very, very important position. Intermediate or cadaveric, this is during complete palsy. Okay, so I told you that what we need to know is that the vocal cord palsy can be either complete or it can be incomplete. So when we know about complete, we already know complete means complete vagus of one side has gone, superior recurrent of one side is completely gone. What's the meaning of incomplete? Now, incomplete palsy usually refers only to the recurrent laryngeal nerve palsy. That is the main motor branch of the larynx. So incomplete palsy, when we refer, we say that it is recurrent laryngeal nerve palsy. So if in any question is mentioned that what will be the presentation of patient in incomplete palsy or in recurrent laryngeal nerve palsy, it means the same. So what will be the position of vocal cord when there is complete palsy? We already know. So when there is vocal cord palsy, can be either complete. So complete, what is complete? Complete is both superior plus recurrent laryngeal. So when there is a complete palsy, what's the position of vocal cord? We already know that is the cadaveric position or the intermediate position. Now when the vocal cord is like this, just see here. What is not possible is adduction. So this palsy is also known as adductor palsy. Now when I tell you this, some of you ask me later on that, okay, adduction is not possible, we understood, but abduction is also not possible, then why is it known as adductor palsy? Yes, so just try to understand here. First thing that you need to understand and remember here is that adductor palsy, when we say abductor palsy, it has got nothing to do with the muscles that are involved. It is named so according to what the vocal cord is not able to do. Adductor palsy means what is not possible? Adduction is not possible. When I say abductor palsy, it means what will not be possible? Abduction will not be possible. So in abductor palsy, the vocal cord will be in median position or in paramedian position. What is not possible is abduction. Whereas adductor palsy means adduction is not possible. Adduction is not possible means what is the position of vocal cord? Yes, it is in the cadaveric position. So vocal cord palsy can be either complete or it can be incomplete. Okay, now I told you that you ask me sometimes that when it is in cadaveric position, okay, we understand that adduction is not possible, but cadaveric is a neutral position, abduction is also not possible. So why are we calling it a adductor palsy? Yes, why? Because if just see this vocal cord, this is the cadaveric position. Here, even if abduction is not possible, abduction is responsible for what? Yes, for respiration. So even if abduction is not possible, there is enough space. There is space for respiration to occur. And if the other is moving normally, so the patient's respiration will not be hampered. So what will be hampered is the speech will be hampered. Why? Because the vocal cord is not meeting in midline. It is not adducting. So for speech, we need a position like this. Both the vocal cords have to meet in midline for the subglottic appreciation to build up. So what is affected because the vocal cord is not being able to adduct. That is why this is what is known as adductor palsy. What is not possible is adduction. Have you understood that? If in any of your question is mentioned, patient presents with complete palsy, or what is the presentation of patient in superior plus recurrent laryngeal palsy, or what's the presentation of patient in adductor palsy. The moment you hear adductor palsy, immediately understand that adductor palsy means what is not possible, adduction is not possible, so vocal cord is like this. Yes. So all these three mean the same thing. The same question can be asked in three different ways. So now what we need to know is that what will be the position of vocal cord when there is adductor palsy? Yes, that is the cadaveric position. Cadaveric position. Immediately with your fingers you can make out adductor palsy. Yes, if it is right adductor palsy means right vocal cord is not able to adduct, it is like this. Left adductor palsy means left is also not able to adduct, it is like this. Yes, so it can be unilateral, it can be bilateral. Immediately, and the moment you know the position, that is the first thing that we need to know. The moment you know the position of the vocal cord, you immediately know the presentation and you know the management. So now what will be the position of the vocal cord when there is incomplete palsy? I told you incomplete palsy is the recurrent laryngeal palsy is mentioned as incomplete palsy. So let us see let us guess what will be the position of vocal cord in recurrent laryngeal. Okay, we know what the recurrent laryngeal supplies. Okay, recurrent laryngeal, if it goes, recurrent laryngeal supplies what? All the muscles except cricothyroid. Okay, very good. So if recurrent laryngeal goes, what goes? Everything goes. What is left behind? Cricothyroid. What is the function of cricothyroid? Yes, it is a tensor. Very good. Also, is it a adductor also? Yes, it is a adductor also. It is a tensor also. So, which means all the muscles have gone. Only cricothyroid is left behind. So, it will keep the vocal cord adducted and it will keep it proper tense. Adducted and proper tense means the vocal cord will be either in the median or in the paramedian position. Adduction is medial to the neutral position. Yes, so either median position or paramedian, both are adducted. So the cricothyroid will keep it in median or it will keep it in paramedian position, and proper tension is also there of the vocal cord. So the position of the vocal cord will be median or it can be paramedian. And this theory is what is known as Wagner and Grossman theory. What is Wagner and Grossman theory? That all muscles are gone in recurrent laryngeal nerve palsy, all muscles gone, all muscles gone except cricothyroids that will keep the vocal cord in median position. So if you know these two positions of the vocal cord, and this is because of injury to which nerve, you know most of the vocal cord palsy. So now quickly let us make a table. Yes, unilateral recurrent laryngeal, bilateral recurrent laryngeal, they can be also mentioned as unilateral, bilateral, incomplete, or they can also be mentioned as unilateral and bilateral. Recurrent laryngeal palsy means what is not possible? Yes, recurrent laryngeal means the position of the vocal cord. We just have to remember two positions. Do not forget that. Just by even if you are while you're sleeping, anybody asks you, yes, if recurrent laryngeal nerve palsy, what is the position of vocal cord? If complete palsy, what is the position of vocal cord? These are the only two positions of the vocal cord that you need to remember. Recurrent laryngeal nerve palsy, yes, only cricothyroid is present, so it is median position, or maximum maybe paramedian. If it is complete palsy, it will be intermediate or cadaveric. So this position, recurrent laryngeal nerve palsy, is also known as what palsy? What is not possible? Abductor is not possible. So abduction. So it can also be called as abductor palsy. And the complete palsy, where the vocal cord is like this can also be called as what? Adductor or abductor palsy. Is what is not possible? Adduction is not possible. So this is also known as adductor palsy. Adductor. It is also known as unilateral or bilateral adductor palsy. Okay. So what are the things that we are going to see here is, yes, the various functions of the larynx that we saw initially, how are they going to get affected? Okay. So now you are going to tell me I'm just going to show you the position of the vocal cord and you are going to tell me the presentation of the patient. Okay, so unilateral recrolaryngeal palsy. So right recrolaryngeal palsy. Quickly tell me the position of the vocal cord. Right recrolaryngeal palsy. Right vocal cord will be in which position? Okay, median or paramedian. Let us suppose it is in the median position and the left vocal cord, it is normal. It is moving normally. Okay, so this one is fixed in this position. It is only this much. It is not moving at all. It is only in the median position or paramedian position. It is not moving. The other one is moving normally. Okay. So now tell me, how will be the speech? Speech. For speech, we need a position like this. So how will be the speech? Yes, speech will be normal. So, okay, the speech of the patient in unilateral recrolaryngeal will be normal. Respiration. How will be the respiration? This is in the median position and the other one is moving normally. So respiration also normal. Okay, respiration also normal. Aspiration. For aspiration to occur, what should happen? Yes, for aspiration to occur, the sensory nerve supply above the true vocal cord, that is the sensory nerve supply of the supraglottis, should go. Secondly, also there has to be a space here. Space in between the vocal cord so that the food or the foreign body can get aspirated. So here in recrolaryngeal palsy, the sensation at the vocal cord and below that is going supraglottis, the superior laryngeal is normal. So that is not affected. Also there is no space here for aspiration to occur. So will aspiration occur? No, aspiration will not occur. So aspiration is absent here. Okay. So how will you manage this patient? What's the complaint of the patient? Speech is normal. Respiration is normal. There is no aspiration. Maximum, if the vocal cord instead of median, if it is in paramedian position, then maybe the patient will have slight hoarseness, but only initially. Why? Because in paramedian position, what's the distance of the vocal cord? Just 1.5 millimeters, and that gradually over some time the normal vocal cord will be able to cover. So even if there is some hoarseness initially, that will be covered. So if there is no symptoms, do we have to do anything management? No, nothing, just conservative management. So speech is normal. Most of the time you will not even come to know unless and until the patient has had little hoarseness. So it can be either normal or it can be slightly hoarse. It can be either normal or there can be slight hoarseness, and management is conservative. Conservative. Nothing needs to be done. Nothing needs to be done. Okay, now bilateral recrolaryngeal palsy. Quickly tell me the position of both the vocal cords. Position of both the vocal cords. Bilateral recurrent laryngeal nerve. Yes, recurrent gone. So all muscles gone. Tricothyroid left. Yes, so median. Okay. So both the vocal cords in median position. Tell me the speech. Speech. Okay, speech will be, we need this position for speech, normal. Respiration. Now what will happen to respiration? They are like this. They are not moving like this. During respiration, we need some space for the air to go in. So no, that is not there. So this patient will present with stridor. Yes, the patient will present with stridor. Can you tell me what will be the stridor here? This is a glottic condition at the level of the true vocal cord. What is a stridor? Yes, it is usually inspiratory or it can also be biphasic. Rarely it can also be biphasic. So patient will present with the stridor. So if I ask you which is a life-threatening vocal cord palsy, immediately you imagine that yes, life-threatening means patient is not able to breathe, so vocal cords are in the median position. So this is which vocal cord palsy? This is bilateral recrolaryngeal palsy. What about aspiration? No, aspiration will not be there. Yes, sensation above is also gone, no space also, aspiration will not be there. Okay, so here mainly patient will present to you with stridor. So whenever the patient has presented to you with stridor, the moment you see stridor in the question, you immediately get the position in your mind. You can immediately make the position of the vocal cord with your fingers. Stridor means no space. This is the position. So this is which vocal cord palsy? This is bilateral recrolaryngeal palsy. What to do? Patient is in stridor. Do something immediately. Patient will die. He is in stridor. Yes, okay, so immediately at least do some emergency procedure. Yes, you have done a tracheostomy. Life of the patient is saved. Will this patient live with a tracheostomy for life? No. Later on what we can do is we can lateralize one vocal cord. So what is done here is first we can go for tracheostomy. And later on we can go for lateralize the vocal cord. We can lateralize the vocal cord. Yes, one vocal cord we can lateralize. So the moment you have the position in your mind that this is the position of the vocal cord, you know what needs to be done. There is no space, so you need to create space. Yes. So how will you create space? Lateralize the vocal cord. So if it is asked that which is the life-threatening vocal cord palsy, immediately it comes to your mind. Okay, life-threatening means no space. So which vocal cord palsy presents with stridor? Yes, again no space. Or if in other words, what is asked, lateralization is done for which vocal cord palsy? So lateralization means yes, vocal cord has to be like this. Only then you are going to lateralize. So when the position comes in your mind, you know the symptom, you know the presentation, you know the management. Now unilateral complete palsy. Yes, tell me what the presentation of the patient will be when there is unilateral complete. Unilateral complete, first you tell me the position of vocal cord. Yes, unilateral complete means one side complete vagus has gone, so the position of the vocal cord is cadaveric. Okay, speech. Yes, not possible. What is that known as? Aphonia. Yes, maybe later on 1.5 millimeters will be covered. Complete 3 millimeters will never be able to cover. So maybe later on the voice will become dysphonic, will become hoarse. But yes, initially when the patient is presented with what? With aphonia. So now the patient has aphonia. Later on maybe dysphonia. Yes, respiration. There is so much of space here and this is also moving normally. So respiration is going to be normal. Perfect. Respiration will be normal. Aspiration, complete palsy. One side complete palsy. Superior is also gone. Sensation above in the supraglottis is also gone. And yes, there is so much of space here. Aspiration, yes, will be there. But here it will not be chronic aspiration. Why? Because the sensation of the other vocal cord is normal. The one side the sensation is normal. So yes, aspiration will be there but occasionally. So aspiration will be occasional. What to do? The moment you have this position in your mind, you know what to do. What should we do? We do not want so much of space there. That is creating all the problem. That is creating aphonia. That is creating aspiration. So what do we do? Yes, medialize the vocal cord. So we have medialized the vocal cord. Yes. Will the speech become normal? Yes or no? Yes. Will the aspiration now be better? Yes or no? Yes. So we are doing medialization. So whenever it is asked, medialization is done for which vocal cord palsy? So if you are doing medialization, means that the vocal cord at least should be like this. Only then you will medialize. Yes. So management, what you are going to do here is you are going to medialize. Okay. Now bilateral complete palsy, both the vocal cords, bilateral complete, yes, both cadaveric. Speech, not there at all. So what will be right here? Aphonia. Totally it will be aphonia. Respiration, so much of space there, normal. Aspiration, yes, superior also gone. And so much of space also. So sensation also gone, space also. So yes, there will be chronic aspiration. Can you imagine anything that the patient is going to eat or drink? It is going to get aspirated and that is going to cause recurrent lung infections, pneumonias, lung abscesses. So what to do? Okay, medialize one vocal cord. I have medialized one vocal cord. Still space is there. Still aphonia, yes or no? Still aspiration, yes or no? Yes. So then, okay, medialize both the vocal cords. Okay, we will medialize both the vocal cord and then we will tell the patient that what you will die later on because of lung complication and aspiration, go and die now because of stridor. No? Then we need some space for breathing. So what do we do? Yes, we are going to do a tracheostomy. Now in this patient, why do we need to do tracheostomy? There is already some space. There is already a lot of space for breathing. Yes, we are going to do tracheostomy because we are going to close the inlet of the larynx to prevent aspiration. So if we are closing the inlet, how will the patient breathe? So we are first going to do a tracheostomy and then we are going to close the inlet of the larynx. What is the inlet formed by? Quickly tell me. The inlet is formed by epiglottis, area epiglottic fold, arytenoid. So we are going to pull down the epiglottis and suture it to the two AE folds, that is known as epiglottopexy. So what we are going to do is, we are going to do tracheostomy. We will do tracheostomy and we are going to do epiglottopexy. So the moment you have the position of vocal cord in your mind, you know the presentation, you know the management. Yes, now before we proceed, you are going to quickly tell me lateralization is done for which vocal cord palsy? Lateralization, quickly tell me, lateralization. Yes, so lateralization, the position has to be like this. Yes, bilateral, Recurrent nerve palsy. Okay, medialization is done for which vocal cord palsy? Medialization, so it has to be like this, yes? So which vocal cord palsy? Unilateral complete palsy. Okay, which vocal cord palsy is asymptomatic? In other words, conservative management is for which vocal cord palsy? Unilateral recurrent laryngeal nerve palsy. Okay, so now we know about complete palsy and recurrent laryngeal nerve palsy. Now, what will be the presentation if there is a superior laryngeal palsy? So, if the superior laryngeal palsy occurs, it can be either a complete palsy of the superior laryngeal where both internal and external will go, or it can be only internal palsy or only external palsy. So, if there is only internal palsy, what will be the presentation? The sensory above the true vocal cord will go. The sensation above the true vocal cord will go. Yes. So, if the sensation goes, what will happen? There will be aspiration. Aspiration. So, whenever there is aspiration given in the question, which nerve has gone? Yes, the internal laryngeal. So, it can be either internal laryngeal, it can be the superior laryngeal, or it can be a complete palsy. Is that clear? So, then we have three options. Okay, so next thing what you are going to look for is the external laryngeal. If external laryngeal goes, what goes? External laryngeal goes means the only muscle supplied by external laryngeal is cricothyroid. So, what will go? Will the adduction and the cricothyroid is what? It is adductor and it is tensor. Will the adduction be affected? Rest all the muscles of the larynx are adductors. So, adduction will not be affected. What will be affected is tension. Tension. Yes, when I showed you the video there of the stroboscopy, I showed you how the vocal cord increasing the pitch. When you were increasing the pitch, how the vocal cords were lengthening. The tension was increasing. And what was that muscle? That was the cricothyroid, the main tensor which increases the tension, increases the pitch, increases the length. So that will be gone. So when you examine, the patient will tell you that I'm not able to raise my pitch. When you examine the larynx, you will see that yes, the vocal cord is it is not tense like that, it is a little bowed. And when you ask the patient to raise the pitch, he will not be able to raise the pitch because this vocal cord he will not be able to tense. Yes, so this vocal cord will be bowed. This is known as skewed position of the vocal cord. Skewed line means a curved line. Yes, so it is bowed. B-O-W-E-D, not B-O-R-E-D. B-O-W-E-D. Yes, so this will be bowed. Yes, so this is external laryngeal will go. So what will happen is there will be inability to raise the pitch. Inability to increase pitch. To increase the pitch of sound. In these patients, usually the speech therapy works where there is an inability to raise the pitch of sound. Only one muscle is gone, the cricothyroid. So the physiotherapy, the speech therapy works in these patients. So now let us see that what you know is that any patient, if aspiration is mentioned, quickly tell me, aspiration is mentioned, which nerve will you think of? Superior laryngeal, we can think of the base of skull injury, we can think of at the level of the hyoid, that is at the level of carotid triangle, at the level of the larynx also there can be injury. If there is any patient who is presented with stridor, only stridor, yes, only stridor means then the site of injury is where? Only stridor means what are we doing? Yes, only the recurrent laryngeal is gone. So it can be either, it has to be bilateral recurrent laryngeal. So bilateral recurrent laryngeal in mediastinal surgeries, can both the recurrent laryngeal be injured? No, only the left will be injured. So it cannot be a mediastinal surgery. It has to be either a neck or thyroid surgery. Most common cause of unilateral as well as bilateral recurrent laryngeal nerve injury is thyroid surgery. So it can be a thyroid surgery, it can be you are working on the esophagus, or the hypopharynx is where you're working, or you're working on the cervical spine. So all these can lead to bilateral recurrent laryngeal nerve palsy, can present with stridor. So yes, you need to write down here. Yes, most common unilateral and bilateral, this is most common, is bilateral recurrent laryngeal nerve injury is what? Is thyroid surgery. Is thyroid surgery. Okay, now if what is it mentioned is skull-based surgery, then it can be a complete palsy also. If it is mentioned bilateral complete palsy, what was the management? If you remember, what is the management of bilateral complete palsy? Bilateral complete palsy, both the vocal cords are like this. So we are doing tracheostomy and we are closing the larynx. Okay, now just think and tell me, you have done a tracheostomy and you have closed the inlet of the larynx. Will this patient ever be able to speak? Will he ever be able to speak? You have closed the larynx. No. So this patient came to you with what complaint? Patient came with aphonia. Yes. You have this position in your mind, you know the presentation. Patient came with what? With aphonia and he came with chronic aspiration. Yes. So what did you do? You did tracheostomy and you closed the inlet of the larynx. Will this patient ever be able to speak? No. So are you correcting aphonia in this patient? No. What are we correcting is chronic aspiration. Yes. So this patient will not be able to speak, and don't feel so bad about it. Bilateral complete palsy means both the vagus completely have gone. This cannot be a surgery where you have operated both the base of skull, managed to injure both the vagus completely. Yes, it means that the patient has a lesion in the base of skull, usually a tumor or any major lesion of the base of skull, which means that the life of the patient is already limited. And this chronic aspiration is making the life even more difficult for the patient. So what we are doing here is we are preventing chronic aspiration. So now, if in a question is given, how will you manage stridor? The patient presented with following upper respiratory tract infection, following thyroidectomy, following any condition, stridor is mentioned. So immediately you know stridor means what? Yes, like this. So how will you manage this patient? Stridor means, yes, you will lateralize the vocal cord. If it is mentioned in a question, patient presents with aphonia and aspiration. Show me the position of vocal cord. Aphonia and aspiration. Aphonia and aspiration. Okay, aphonia and aspiration can be, okay, one side there is space, one cadaveric, one unilateral complete palsy, aphonia and aspiration. It can be bilateral also. Is the management of both of them the same? No. No. In unilateral we medialize, in bilateral we do epiglotopexy and tracheostomy. So what should we answer? Depends upon what is asked next. Yes, if it is given that patient presents with aphonia and aspiration, so we have these two things in mind, aphonia and aspiration, either unilateral or bilateral complete palsy. Now next in the question is asked, how will you correct the aphonia of this patient? So if it is asked, how will you correct the aphonia? How are you correcting the aphonia? Yes, which means in which palsy? In unilateral or in bilateral are you correcting the aphonia? Yes, in unilateral what are we doing? We are medializing. So when we medialize, is the aphonia corrected? Yes, the speech becomes normal. In bilateral complete, what do? We do tracheostomy and epiglotopexy. Are we correcting aphonia here? No. What are we doing? We are correcting aspiration. We are correcting aspiration. So I hope this part is clear. Now when you actually do the questions, you will understand that yes, what we are doing now, we are able to answer each and every question. So do the questions, yes. Okay, now before you do the questions, we need to know how do we medialize and how do we lateralize, okay. So here we have, again we have the epiglottis, we have the aryepiglottic fold and the arytenoid. The aryepiglottic fold and the arytenoid, yes. Okay, so now we have this vocal cord which is like this, okay, this is like this, and we want to medialize this vocal cord. So how should we medialize? Yes, what we can do is we can inject something laterally. We can injection of, what we can do injection of? Injection of collagen, injection of silicone, injection of fat, injection of calcium hydroxyapatite, injection of Teflon. Teflon used to lead to a lot of granulation, so that is why it is not usually preferred. Nowadays the rest are preferred. So when we are injecting, what we are doing is we are pushing the vocal cord medially. So what are we doing? We are medializing. Now suppose this is the vocal cord which I want to lateralize. Okay, this is the vocal cord and I want to lateralize it. So how should we lateralize it? Yes, for lateralizing, what we can do is we can cut the vocal cord. We have cut it. If I have cut it, what have I done? I have done cordectomy. I can cut it. I can also remove the arytenoid posteriorly, cut the arytenoid from posteriorly. Yes, so what have I done? I have done cordectomy plus I have done arytenoidectomy. Cordectomy plus arytenoidectomy. This cordectomy or with arytenoidectomy or without arytenoidectomy, the surgeries have been named. One of them is what is known as the Woodman's procedure. One is known as Kashima's operation. Kashima's operation, exactly what they are, you need not know what exactly is done. All you need to know is that yes, cordectomy, ethnoidectomy, lateralization. So all the lateralization procedures are named, whereas medialization we are just injecting something, yes. So ethnoidectomy, cordectomy, all this is what is lateralization, or cordopexy. Again, cordopexy means lateralization. Cordopexy. Here what we are doing is we are burning a part of, we are removing a part of the vocal cord with the help of laser. We are just burning that area, yes, so that it lateralizes, so that some space is created. Now also for medialization and lateralization, there are some thyroid framework surgeries which are known as thyroplasties. So the thyroplasties, what are thyroplasties? Then the mnemonic is in the name itself, thyroplasty, P-L-A-S-T-Y. So what is P? P is proximalization. P is proximalization, making the vocal cords proximal, or this is medialization. Proximal or distal. Yes, proximal is medialization. L is lateralization. S is shortening. And TY is tightening. Tightening, or tightening means what? Lengthening. Tightening means lengthening. Okay, so now this is what we are doing here. You are going to tell me that when will we medialize. So this is 1, this is 2, lateralization is 2, shortening is 3, and tightening is 4. Okay, so you tell me now, when are you going to medialize? When are you going to medialize? In which vocal cord palsy will you medialize? Yes, immediately. Yes, show me the position of vocal cord when you want to medialize. Yes, one is like this. So that is what palsy? Unilateral, complete palsy. Unilateral, complete palsy. Okay, lateralization. When will you lateralize? Show me the position of vocal cord. Yes, it has to be like this. So we want to lateralize. Okay, so this is which palsy? Bilateral. Bilateral incomplete, or bilateral recurrent laryngeal, or bilateral, is it adductor palsy? Bilateral adductor palsy or bilateral abductor palsy? What is not possible? Abduction is not possible. So yes, bilateral abductor palsy. Okay, when will you like to shorten? Shorten. Yes, shortening is done for puberophonia, and tightening is done for opposite of puberophonia, that is androphonia. Androphonia. Okay, now tell me what is the meaning of puberophonia. What is puberophonia? Before coming to, okay, what is puberophonia, what you need to know is thyroid. We did first that for medialization, lateralization, we are injecting or we are cutting. So is the thyroplasty different from this injecting and cutting? Yes. Thyroplasty, we are not working on the vocal cord at all. What we are doing is, it is thyroid framework surgery. Thyroid framework surgery means that we are doing something on the thyroid framework, on the framework of the thyroid cartilage, to medialize, lateralize, shorten or lengthen the vocal cord. Now let us see. Just see this picture. What we have done here is, we have cut one chip here. One chip we have cut of the thyroid, and we have put a block medially which pushes the vocal cord medially. So we have not done anything to the vocal cord. We have worked on the thyroid cartilage framework to push the vocal cord medially. Similarly, just see this picture. Now in this picture, what we are seeing is that this vocal cord, this is the vocal cord, and this vocal cord I want to shorten. I want to shorten this vocal cord. So what I do is, I remove this chip of the thyroid cartilage. I remove it. Just see here, we have removed this chip, and we have the cut ends we have fused together. So ultimately this vocal cord has shortened. Similarly, we can do it for here also. We can remove this chip and we can remove it. So this vocal cord will also get shortened. So we are not doing anything to the vocal cord. We are working on the thyroid cartilage framework. That is what is thyroplasty. Okay, so now what do we do in puberophonia? What exactly is puberophonia? How is the voice in a child, be it a male or be it a female child? How is the voice? Yes, it is a high-pitched voice, high-pitched female voice. Yes. So if it is a child who is speaking to you on phone, you will not come to know it is a girl or it is a boy. Both of them have a high-pitched voice. So, does it change at puberty in males? Yes, in males, the voice becomes a low-pitch voice. So, what changes in males that the voice becomes a low-pitch voice? Yes, in males, what happens is that the larynx, as the larynx grows, the larynx grows more in males. And because of growing of the larynx in the males, what happens is that the vocal cords, they become relaxed. So just try to understand this, okay? If you do not understand this, you will not understand why we are doing shortening. Yes. So now what happens in males, just see here. This here is the larynx of a child, okay? And this is the vocal cord. In males, what will happen is that the larynx, the diameter grows. Yes. The larynx grows. Yes, the larynx grows. And the vocal cords also lengthen. The vocal cords also lengthen more than females. So now, the diameter of the larynx also increases, but the length of the vocal cord increases much more than the diameter of the larynx, which means that now in this much diameter we have a very lengthy vocal cord. So for it to adjust in the larynx diameter, the vocal cord becomes a little relaxed. It can tense itself, but normally it is a little relaxed because the length of the vocal cord has increased much more than the diameter of the larynx. So now the vocal cords become relaxed. So because of this relaxation of the vocal cord, the high-pitched voice of a male child turns into a low-pitched voice of an adult male. And this we have seen, if you have played any instrument, you must have seen that with the same string, we can produce a high-pitched and a low-pitched voice. When we want to produce a low-pitch, what we do is, we loosen the string, we loosen it, we relax it, and when we want to produce a high pitch, we tighten it. Yes. So so now what happens is that the male child now develops a low pitch voice of an adult male. Now if that fails to develop, then the voice of an adult male remains the same high pitch voice of the child, and this is what is known as puberophonia. Puberophonia, also known as, it is known as mutational falsetto. Yes. So the voice remains a high pitch. Yes. Male voice, adult male remains high pitch. So which means that the vocal cords have not relaxed enough. So what we can do is, we can relax the vocal cord. So in shortening, we are not cutting the vocal cord short. What we are doing is, we are relaxing the vocal cord. So we are compressing the larynx from anteriorly, the laryngeal framework, we are compressing from anteriorly so that the vocal cords become a little relaxed. So this is what we are doing in shortening. In lengthening also, we are not adding on to the length. What we are doing is, we are stretching the vocal cord. So in females who have got a low pitch voice, they do not have a high pitch voice, then in them to produce a high pitched voice, we want to lengthen, we want to stretch, we want to tighten this vocal cord. So for them, what we go is for type 4 thyroplasty, that is tightening of the vocal cord. We call it as lengthening. We are not adding on to the length, we are just stretching the vocal cord. So in any patient, in any adult male who has got a high pitched female voice, before we go for the thyroplasty type 3, that is shortening, that is relaxing the vocal cord, we can test whether this relaxation is going to help him or not. So now let us see what we are going to do. We are going to compress the thyroid posteriorly and downwards. Now look at my voice, how it is. Yes, so that leads to low pitch voice. So if that leads to low pitch voice, which means that the vocal cords can be relaxed, and this can lead to a low pitch voice in the adult male. This test is what is known as the Gutzman pressure test. And if the Gutzman pressure test is positive, then we go for the management, and that is type 3 thyroplasty. That is type 3 thyroplasty, that is shortening or that is relaxing the vocal cord. So this is how we are going to manage any vocal cord palsy, either by medialization, lateralization or by thyroplasty. So now let us quickly do a few questions and see whether we can answer or not. Maximum stridor is seen in. Stridor means immediately we know which palsy it is. Yes, both the vocal cords in midline. So now you will tell me what palsy is this. Yes, unilateral incomplete. Unilateral complete, bilateral incomplete. What's the answer? Okay, bilateral incomplete. I will give you only 30 seconds. Okay, you have 30 seconds for one answer. I think that is also more. You will be able to answer immediately. Bilateral abductor palsy. Abductor palsy. Abductor palsy means what is not possible? Abduction is not possible. So it is okay. All is done except what you do not want to do. What you do not want to do. Yes, you do not want to medialize. Already medialization is there. What will you not do? Medialize. What you want to do is lateralization. So yes, what will you do here? What will you not do? Chordectomy, nerve muscle implant, retinoidectomy. Nerve muscle implant can be done for both medialization as well as lateralization. We can, the muscle that is gone, the nerve that is gone, we can implant another nerve there. We can anastomose another nerve to that muscle for functioning of that muscle. So it can be done both for adduction as well as abduction. So yes, what we are not going to do is Teflon paste. Okay. So which means whenever it is mentioned stridor, patient is in stridor, what can be asked you? Okay, patient is in stridor, what is this palsy? Bilateral retinolaryngeal. Okay, patient is in stridor, what will you do? What will you do? Lateralization. Or patient is in stridor, what will you not do? Stridor, what will you not do? It's medialization. Only these questions can be asked. Nothing more can be asked here. Okay. Next question, let us see. Aphonia of adductor palsy. The moment you have adductor palsy, show me the vocal cord. Yes, show me the vocal cord. You should have the vocal cord in your mind for knowing what the presentation and what the management. Presentation is given here. Aphonia and adductor palsy. Adductor palsy means, yes. So what is the position? Okay. Either like this or like this. Okay. So now what? It can be overcome by. So what is being asked is we want to overcome the aphonia. So in which one will we overcome the aphonia? Very good, in lateral complete. How will we overcome? Yes, medialization. So what will be the answer? Yes, Teflon paste injection. Okay, 30-year-old female following URTI presents with stridor. It can be managed by following except. So stridor, what will we not do? Yes, will we not do is medialization. Which one is medialization here? Tracheostomy, cordectomy, type 1 thyroplasty, type 2 thyroplasty. What is this? Yes, type 1 thyroplasty is medialization. So this is not what we are not going to do. So just open your books and finish all the questions and see whether you're able to answer all of them or not.